a Heroes Welcome podcast.
Hello, listeners. Thank you for joining us on a Heroes Welcome podcast, your ultimate guide to understanding the incredible world of mental health. I am Maria Laquerre-Diego, licensed marriage and family therapist and registered play therapist supervisor, and I am joined with my co-host.
That's me, Liliana Baylon. I'm an LMFT and RPTS because I'm too lazy to name everything that Maria just did. And we're here with our special guest. Do you like to introduce yourself?
Yeah, I'm Tareq Yaqub. I'm a child and adolescent psychiatrist. I primarily do inpatient psychiatric work. I also help run a refugee clinic that does forensic and diagnostic evaluations for unaccompanied minors and other children seeking asylum. But that's expanding to, hopefully to have the capacity to serve all newcomer children. I was formerly a fellow of the American Psychoanalytic Association as well.
Excellent. And you're practicing where?
At Lurie Children's Hospital.
And where is that located?
That's in Chicago, Illinois.
Oh, okay, cool.
Yeah.
Because we're all over the place on our podcast, so we like to be able to highlight that. So as you know, this is kind of our safe space to have the conversations that aren't necessarily said out loud or in other spaces. So what would you like to start with?
Dun dun dun. You can go anywhere.
I mean, there's so much going on, and like mental health is anytime I get invited to speak about mental health, I'm like, what about it? It's just such a huge field. It's just, and so a lot of the work I do, I do clinical work, and I'm also an assistant professor of psychiatry at Northwestern's Feinberg School of Medicine. So, I mean, one of the things I try to relate to learners and to myself always is this commitment to look at, I know everybody says this, what does it mean to look at somebody who comes into your office or is it you see in the hospital holistically? What exactly does that mean? Because, what is a holistic approach? I think when you work with children, what that means is exploring an actual genealogy of how did they present here? What's their parents' life been like? And if you can know something about grandparents, that's always helpful too. Their ability to relate with family and peers too. So what's going on in the relational aspect of things? And, what's going on structurally and systemically? How do they identify both from a racial status, from an orientation status, from a gender identity status, from a religious standpoint? Where do they live in the city? What resources do they have access to? What insurance do they have? Not because I'm looking to get paid, but what resources are they going to have available to them? Is transportation available? I mean, all these things are things we have to think about, and you have to more acutely think about them when someone's presenting to you in crisis. And I think a lot of the models we have in crisis and when someone presents with a mental health emergency in the emergency room or the inpatient is acute stabilization, right? But what does that even mean if you're setting someone up for a life that's not conducive to wellness? And so what does it mean to bring family in? What does it mean to find out about, not only interpersonal violence and abuse, but the ways in which people are denied care and education and school accommodations and whatever it may be as a form of violence as well. And I think those are the things we have to think about a lot. And how does ways of relating to people and systems and structures also get passed on through families? Where is their trust? What is the belief system? Where is their mistrust? And so that's a lot of the work that I do, or I try to do, you know. I think we all fall short of that ideal, unfortunately. And once you are able to say like someone was acutely stabilized, there's always that feeling, are they going to slip through the cracks? Are they going to have the resources available to them? I can recommend all these therapies and stuff, but if they have one parent who works and doesn't have a car, what are we going to do? And then, I know we all practice in different places, but especially in Illinois, in the city of Chicago, compared to other places I've worked, the resources for follow-up or in-home services are just so nowhere near where they need to be, which is quite devastating as a practitioner. It really hurts morale, but for families, it's just you're not setting them up for wellness. You're just trying to set them up to hopefully the next crisis isn't as bad. And that's a cycle that doesn't feel great.
Yeah. And you guys can't see us, but Liliana and I are like nodding our heads. So you're in good company. We are both systems thinkers, just by our own education and training. And yes, the barriers to long-term continued treatment and health versus just slapping a Band-Aid to call that crisis good, and passing it off. Yeah.
And right as you were talking, I was like, oh, pardon my language, holy shit, I have someone else who thinks like me. Because I work with DACA recipients and I work with newcomers who are seeking that part, often have to think about, okay, so how are you going to get from your place to my place? Which when we are in private practice or certain agencies, we don't think about transportation. And then it's like, okay, so what are the accommodations that I have to do? Because if you have to take public transportation and the bus breaks down, how are you going to get to me? And am I thinking that you're not respecting my time, or am I understanding the process from one place to another? Because I have been there. Right. And those are things that we don't take into account. And then even as you're talking, right, which is from a system perspective, tell me how you identified. We tend to focus right now on pronouns, but we stop there. And then, so what about, your identity, your acculturation, assimilation, like how all of these making sense to you? And I don't think in our field, we think that way when we're talking about any subpopulation. It's a specialized population that you're discussing. And I don't know about you or you two, but when I go out and talk to others, they don't talk like me or think like me. And so between the three of us, I was like, oh my God, we think the same. But is it because we worked on this population, or because we're other and we're thinking of all those layers because we have been there?
I think that's an interesting point. The other thing I heard was considering system traumas that have been impacting that client, child, family system, because that really deteriorates their willingness and their feeling of safety seeking help and support. Are you also kind of seeing that in your practice?
Yeah. I mean, you just brought up so many things. So my mind was racing, and I was, yeah, systemic trauma. But when I heard that, I think about the ways we think about trauma in general. And, I often work with highly, quote unquote, traumatized populations, right? Whether it was through forced displacement, or whether it was abuse in the home, or violence in their neighborhood, or whatever it may be. And I think we often have this expectation, because we want to be trauma informed, that someone who has experienced trauma is going to be traumatized and helpless and victimized. I can't tell enough stories about kind of not championing or approaching someone's ability to persist and be resilient, right? I think I see children who have, you know, migrated across 3 countries unaccompanied,
Yeah.
seen and witnessed some of the most horrific conditions. And what they really want is to be able to just have a group of friends that have the same interests as them. That's kind of like the most trauma-informed thing. They don't have like a lot of the symptoms we often consider as someone who's heavily traumatized. They manifest in different ways. Obviously, maybe they're distrustful of others or they really feel othered, but they're not having like a lot of the times like what we think of like this social withdrawing or marked irritability or nightmares or whatever. They're traumatized.
Mhm.
What they're really looking for is an ability to find someone who, like we were talking about, thinks like them, has similar interests, knows the shows they watched in country of origin, knows the same games. Like they're having their whole cognitive and psychological apparatus has to be reformulated. Like none of their peers speak the same dialect or have play the same sports or know the same celebrities, and that's something we're not focusing on in treatment. Like a lot of our treatment is manualized, or suggested treatment is manualized and depoliticized, right? It's not about reestablishing a sense of cultural and national consciousness, right? And it's not about incorporating the cultural narratives, right? And I've talked a lot about this, specifically when I use Palestine as a case study of this, where the studies, often in the West Banks, they've done like ethnographic studies of children who've had their homes bulldozed, right? And it's super traumatic. And these models of like trying to process the actual bulldozing of the home without giving people this, like without using the cultural markers or these cultural signifiers, like this concept of sumud, which is steadfastness, or maqama, which is resistance, and not naming the occupation and not naming the structural violence did not led kids to go worse. Like they have, and this is what some other psychologist, Laura Shihab, recently said in a talk, is like these children and the people in Gaza show us what it's like to have a political commitment to hope. And how we present hope as in mental health is depoliticized. It's what is your future orientation, right? That's our
Right.
question. Like what are you gonna do next week for fun, But
Right.
our political commitment to hope is I envision a land where we're all free, where where I can hear birds, not bombs, where, everybody has food to eat. And that's not just specific to Palestinians, right? I think we see populations who are part of a broader collective, and we give them an individualized treatment that doesn't incorporate that collective communal feel, right? And that's alienating, and the treatment doesn't see the same effects that we expect it to.
Right. Right. And I have to think that on some level is either starts or is perpetuated by the fact that, like, we use the DSM in the mental health world, right? But who was the DSM developed around in terms of like what is healthy and what is normal and what is optimal living? Right? Like let's name it. Like that is done for cis, hetero, white, mid to highly influential and income-based families. That does not at all incorporate any culture other than the dominant culture. And so we're teaching new clinicians and uprising, helpers to only view things in that small scope.
And I love, right? Because when we were discussing early, which is what we get from media is like what we get from the DSM, what we get from insurances, what we get from the agencies that we work with, which is this stereotype and this script that we get to repeat over and over again, and we don't take into account the client that is in front of us. When a lot of, especially the population that you're discussing, which is a lot of the time the newcomers, when they come in, they're seeking for, where can I go? I don't know about you, but for me is, where can I go, Latinos, where can I go play soccer? Who has a soccer ball? And then they're trying to do that. Or where is the soap opera? What channel? Where is the common dialect that we can have? And that's a very stereotype too, but not according to my mom, which Monday to Friday, I cannot talk to her in a certain period of time because that's her TV time.
Telenovela time. Yeah, you don't mess with that.
Telenovela time. So, oh my God, like that just came out like, oh, that's right, I cannot call at that time. But what is it? Are we aware as therapists of the script that we're being told by agencies, by systems, period? And then that's something that we have to meet requirements. But then when we're in front of the client, can we let go of that? And can we get to know the client? Can we let go of what we're being told of what to do, even from a model perspective? Because everyone right now is like, do this model with all clients. And I'm like, actually, no, that's not going to work for all clients. I cannot go completely expressive. I cannot go completely in neuroscience. I cannot be loyal to a model the same way that I cannot be loyal to the DSM book, because it's just not going to work for the population that I'm serving. Yeah. But the invitation of what you're discussing, which is, can we be open when most of the dominant culture are talking about mindfulness, right? Can we be open to talk and get to know the client from different layers of systems and that shared experience that they're looking for, and how can we join in? Damn, we should write something.
And when it comes to, yes, like who are these diagnoses describing? But also we must think about like, what purpose does a diagnosis serve? And I'm a physician by trade, and I think a lot of the DSM is a legacy of the medical model. You have a diagnosis and a specific treatment for the diagnosis, right? And then it gets better. And I think that really limits our understanding of a human being. I mean, we're trying to make the subjective somehow objective, or somehow, we're trying to confine all the permutations of what can happen in someone's brain and personality and consciousness and unconsciousness into something finite and understood. Yes. And I think it really requires our humility, and I think there's something exciting to say, like, we're just not gonna fully know. But the messaging we get is like that we're gonna give you something, a diagnosis that's gonna encapsulate everything you're experiencing, and you're gonna completely understand yourself once you get this diagnosis. And I can think about multiple scenarios in which that has caused much more harm than good. Sometimes it can be helpful, right? I can think about like someone who's having a manic episode and you tell them this is part of bipolar disorder, that can help, right? But I'm specifically thinking about a very bright adolescent, a high school student who had a suicide attempt, and was diagnosed with depression and a personality disorder, and got like was on like 4 different psychotropic medications when he ended up in our unit. And essentially this was a kid who was was born with a pretty significant physical illness from Southeast Africa, was adopted by a white family, and was reading a lot of nihilistic philosophy, and was just like, the world is unjust, there's no point to it, I'm lucky and guilty, and I don't really contribute anything to the grand scheme of things. And how do I alleviate suffering? I'm too small of a person to do anything about it. So I just want to be out of here.
Yeah.
And I don't think like depression encapsulates all of that, you know?
No.
Or I mean, he was diagnosed with a schizoid personality disorder.
Oh,
And I was just like, this is like, we just, luckily it was me, and my fellow was also like, he was like a philosophy major. So we were just
mm,
talking about different philosophies towards life. So we engaged in the intellectual aspect of things, but we were able to process, you know, these feelings of, I don't feel, what does it mean to be connected to a land and a people I've never known?
yeah,
And to like love and hate the people who have taken me in.
yeah, yeah.
And
It's so complex. It's so complex.
Too many layers, right? Of being other, being adopted, the guilt of like who I left behind, why am I here, why am I, adding to the world, to like you were talking, I was thinking of all the layers that are coming up, and I was like, holy crap, no one saw this. And right, I love the question that you posed, which is, what is the purpose of the diagnosis? And I'm finding myself now talking to supervisees of, what will be the purpose of giving this diagnosis? How is this adding to the client versus just meeting a checklist for systems?
Yeah.
If you give this diagnosis, how will the client take this and personalize it? What is the identity gonna look like if you give this diagnosis? And I don't think, I know for sure I did not came from a systems training where they asked me that question. It was something that I had to learn as I become seasoned therapist, which again, I hate that term because they're just telling me that I'm old.
She says that in every episode.
As a seasoned therapist, which is the conversation that I'm having of, can I humanize you versus dehumanize you with an umbrella diagnosis, which that's what you're discussing. If I give you depression, that is an umbrella, and I really do not get to know you, and I'm dehumanizing you by just giving you this label.
Well, yeah, and for me, it brought up, the humanistic approach. Like, how do we look at the whole human in front of us? And I think this is the dissonance that we, as clinicians, often feel of, like, well, our training is look at the whole person, look at the systems, look at all these things. And then our requirements to be able to bill and have an income are like, they need to fit in a box that does not incorporate all of those things, because depression does not look the same person to person, culture to culture. Even within our own, United States, what I experienced as depression in the clinic I worked at in New Hampshire is very different than what I see here in New Mexico.
Yeah.
And they don't, we make them fit the boxes so that insurance can be satisfied. But that's the dissonance, right? We're wanting to treat the whole person, and yet we are put in this medical model that, depression isn't like a broken arm. There isn't a system like, here's how you treat a broken arm. And it works for 95% of broken arms. That doesn't translate, even though our DSM is very much the medical model, it doesn't translate to the work that we do when we're treating a human.
and I will say, like, getting to know the layers and a person humanistically and holistically is a deeply intimate process. And, I think that word intimacy is kind of makes people uncomfortable, like, because it gets sexualized and stuff. But I'm
Yeah.
saying, like,
Oh,
like
yeah.
it requires a lot of, self-awareness and self-understanding. It requires an ability to be curious and think about things in both, like, what the person is telling you in two registers, like the prose and the poetry, like what's the symbolic meaning behind this, and what are you actually telling me, and how are they related? And that's just not something a lot of us are trained in doing. It's, again, like, what are your symptoms and what are that? And, like, of course, I think it would be bad practice to not get all the symptoms, but like, we need to understand why they're there. And so like oftentimes when I have learners with me, because I have medical students, residents, and fellows, and day one, I say like, I'm gonna ask you why someone is anxious or depressed. Your answer cannot be because they have anxiety or depression. Like that can never happen. Like we're not gonna do that. You're gonna tell me they meet criteria for this, and this is all the things internally and externally that's contributing to that, and historically, obviously, in the person's life. But like that's how we're trained. Someone's anxious because they have generalized anxiety disorder. They're gonna get an SSRI. They're gonna do 12 sessions of CBT, and they're not gonna have this anymore. But maybe, I don't know, maybe it's a recurring episodic chronological disease. Maybe it's a one-time episode. I don't know. But we're gonna treat it the same way.
I wish for our listeners they can see our faces right now.
We all have that smirk of like, yes. I mean, that all makes sense. And why aren't we given the resources? I'm just thinking like time. Because the other thing, there has to be a trust built before someone's going to really fully go through all those layers and share them with you.
Yeah.
And I think part of the intimate process is what people bring to you in crisis obviously elicits memories, big emotions, self-doubt, whatever it may be in yourself. And I really like these models of like reflective supervision or whatever, or whatever different models people have or names they have for this model of like really when you're talking about a case, bringing yourself in. Like I have trainees where like we're dealing with very narcissistic parents, and someone will tell me like, hey, I'm having a really hard time with this because my parent was a malignant narcissist. So like I don't know if I'm ignoring this request because it's the right thing to do, because like I don't want this is self-serving and it's not helping the child, or if it's just like I don't like this person because they're bringing up the hate I have towards somebody else. And so, and I think we need to always be open to conversations like that, especially if we're in teaching positions. But I just, again, like it gets busy. What's the diagnosis? What meta you're going to use? But oftentimes after those conversations, like the clinical example I gave earlier, what ended up happening was we were able to get that child off of most medications, and then reconnect with a therapist that could see them more frequently. And, what stinks about kind of the work I do is because I'm in the acute stage, I often don't get to see what happens down the line. Where I used to kind of do more outpatient work where I could see that. But, if I don't see someone back, I'm hoping that the outcome was good, and usually it is. I'd like to think, but
that idea of working ourselves out of a job, right? Helping people so much that they don't need to come back, especially at an acute level.
We're like those dating apps that are designed to be deleted.
I love that. That's a great analogy. Yeah, and because this is a space where we can say things that don't necessarily get said out loud other ways. I mean, the other thing that I'm thinking of is this increase, I don't even want to say it's access to services, but this quick fix, big platforms that are out there that are like, you can have a therapist in your pocket anytime you need someone, they're right there. But they're also like, it's not whole person treatment. Is very quick turnover. You get this many sessions, or you can pay for this many sessions. But even then, it's not like, who are you? Because some of the symptoms that get listed are only problematic if you are a certain demographic. Some of those are cultural norms and family system norms that the other culture wants to call, unhealthy or a diagnostic criteria.
Yeah. Well, I mean, I think our work should be ethically challenging, meaning like I think every day I'm like, is this right? Like, and especially because I'm
Yeah.
in an inpatient unit. It's a locked unit. Like I'm barring kids from going outside. I mean, they're usually there for about a week, but at some point I'm like, am I part of the carceral system, or am I providing a sterile environment for somebody to work through things because the demands right now in this acute crisis of the outside world are too much to bear? And like I go back and forth, like, you know, especially when kind of someone's main reason for coming in is some sort of aggression, right?
Yeah.
Am I using this as like a temporary holding jail for whatever reason and try to discover an underlying diagnosis that made this person aggressive? And I think that's an ethical conundrum every day, right?
Yeah.
And I don't want to see the day where it's not an ethical conundrum. Like I want to imagine that there are probably some better models out there, right? Um, but I think those better models, in order for them to be actualized, will require a lot more investment from cities, will require a lot more more tolerance for behavior that people find aberrant or
Mhm.
like not normative. Um, and so like those alternative models of treatment, and I think this is why it's important, start not in the clinic. They start with a structural and cultural shift of expanding, one, what it is to be normal,
Mhm.
to investing in communities, investing in care. And that's in so many ways, like who's responding to mental health crises, right? Is it police officers with a gun? Like,
Right.
that's not great for, I mean, that's so euphemistic. That's really bad, especially in
Yeah.
in communities who are often terrorized by police, right? Um,
Yeah.
where do our tax dollars go, right? Are they sent to bomb people, people that look like me, bomb my own extended family members, or
Right.
is it there to provide these, why don't we have a 24/7 center for a for on-call therapist or whatever? I know there's the hotlines and stuff, but it's different when you're in person with somebody, or if someone is trying to go through trying to no longer use substances or whatever it may be, and they're going through a withdrawal that's not going to get them admitted to the hospital, but it's still uncomfortable. Is there a place we could go? Are there in-home services we can provide for children who struggle with managing big emotions or have neurodevelopmental disorders and their parents can't handle the demands of all they need? I mean, these are the models that I think would hopefully in the future alleviate the need for this system of I'm in a locked unit and it's safe and secure and you're working on yourself. Um, that's not to say I don't think it's all bad, but there's a lot of stuff that's not good,
Yeah.
and that's the thing. Like I take pride in the work we do, but a lot of times we have to sit with like contend with like, am I an extension of a model that pathologizes people, that says some people don't belong with the rest of society and need to be imprisoned for a bit to get rehabilitated psychologically? I mean, it's a tough thing to grapple with. And there's some people that will say, like, how can you talk about psychiatry or mental health or psychology as a decolonial practice when it is meant to pathologize and uh, and champion abled minds
Yeah.
Right.
and all this. And so I have to contend with that. Like there's a part of me that wants to be like, yes, we can use this for radical understandings of people and stuff, but also am I extension of something that is not built on actually understanding people, right?
Yeah.
It's built on modifying behavior to make them good working citizens or good students in school and good children. Like oftentimes I have to tell trainees, what are you trying to medicate here? Is it parental expectations or an actual underlying thing that can be moderated or mediated by a medication? Like, is it helpful to the child or is it relieving a parental anxiety or a disappointment?
Oh, that's good. That's real good. I think, I also I was a clinician in an inpatient. So yeah, I feel that in my soul. I was like, and I knew some of what was sent our way was a punishment. It was not true need of that level of care for mental health, well-being and safety. It was a punishment. So yeah, absolutely. And I think what you're speaking to is that, you've got one foot in, one foot out. We have to abide by the systems that are in place, even as though we disagree with them and they don't fit what we want to do. And what can we do to move it to better, right? To some of those future systems that you're talking about and can see as being more holistic. So it is that like one foot in, because we got to get paid and we gotta appease and check those boxes. And what can we do to move away from that system and move into one that is more holistic, and accepting of others?
Yeah. So hopefully for our listeners, as we get into that time where we have to let go, and this is a really good conversation. The invitation sounds like, can you be asking yourself in a daily basis, is this ethical, what I'm doing, or am I participating in a system that is pathologizing the client, the symptoms of the client, because it's not fitting in this box that a bigger system tell me this is what it looks like and this is the umbrella. As I'm listening to both of you, I'm like, that's because you two read the book, Decolonizing Therapy, right? But not everyone is aware of that book. When I read that book, I was like, yeah, this is like given. But it took me time to realize like, oh, that's because I'm other. And I think we need to have more conversations with therapists, human spirit from different backgrounds in order to learn not only from them, but it's easier than to ask the question, is this ethical? Because when I'm just through one lens, I lose myself, I lose the client, and I start making decisions that they're not ethical for the client that I'm serving.
Yeah, I love that. And so we've got a long road ahead of us. Where can people start with this work? I mean, thank you for doing what you're doing, and especially with your students and interns and fellows, because I think they and your community are lucky to have you have this perspective and share your wisdom and knowledge with upcoming providers. And for our listeners who may not have direct access to you, where can they start?
This is a great question. And I think the first place to start, I think, requires starting from a point that challenges this whole idea that neutrality is innocent and that what we're doing is objective. Like what we do in exploring the depths of subjectivity and human experience is inherently a political process, and there's no way around that. And to try to depoliticize it again serves in like I think in a colonial epistemological model that champions one experience over another, which is like what we were talking about, a cis white heteronormative experience, right? And also contributes to us being more paternalistic and diagnostic providers, right? So I think that's the first place to start, to say like, I think objectivity is a myth and I think neutrality is impossible. And so then the next step is to say, are my politics that I'm gonna bring in with me, are they invested in a liberatory praxis, or are they invested in pathologizing and diagnosing? And then in that process, maybe there's some good books to recommend to read. You brought up decolonial therapy. I just started one called Unruly Therapeutic by Feluke Taylor. So I wish I could say more about it because I just started it, but so far it's excellent. You know, I was really influenced by the works of the psychiatrist Frantz Fanon, who wrote The Wretched of the Earth and Black Skin, White Masks, and really thought about how racism and colonization psychologically impact not just those who have been colonized, but also rids the colonizer of their humanity, you know, and that and the psychological processes and that, and thinking about things in a symbolic way. There's so many books, like, you know, one of my biggest mentors I mentioned earlier, Laura Shiha, her and her husband wrote a book about a lot of these same topics we've talking about. It's called Psychoanalysis Under Occupation, and it was about Palestinian mental health clinicians who were being forced models by Israeli or other Western supervisors that pathologized and dehumanized experience under occupation, or just erased the political reality of people and focused on someone's internal world at the expense of what the material reality is, you know? So there's a lot to read. I can't say I've read it all, but I think what is important is that we have to contend with, this is going to be an ethically difficult process, that we need to find ways in which we're invested in liberatory practices and viewing, like investing in us and our clients and our patients, really trying to understand who they are, not through a diagnostic lens, but what is this political commitment to hope we can give them.
I don't know about Maria, and I'm sure she will agree with me, but we can just keep talking to you, just so you know.
I can keep talking to y'all. I appreciate it for having me.
So I'm hoping that you will come back, because there's more actually here. I mean, holy cow, I have so many, like, I wrote down so many bullet points for myself, and I was like, I think I'm gonna reach out to you too. And I'm like, oh my God, if I'm ever in your state, I will reach out to you, because I will just follow you. See what you do with the people who are studying you, because I was like, man, can you imagine? Yes, I'm gonna, it sounds like I'm gonna stalk you, right? But no, I'm asking for consent so I can learn from you. That's what it is.
Again, I always think learning is bi-directional. I love having these types of conversations. And again, like, these conversations hopefully recharge us to do the work, not just in the clinic, but the more important work outside the clinic. So I always end, like, when I give talks about Palestine or others, like, we have important work in the clinic, but are we boycotting? Are we making policy change? Are we demanding divestment from our institutions that are investing in violence and terror, and, you know, food that's unhealthy for people rather than
The whole
things
conversation.
yeah, like, and pollution, and, you know, like, and alienation from land is a big thing we don't talk about too.
Yeah.
Like, I recently was I was in like a panel discussion with a local union, and one of the things that the icebreaker was like, what is your favorite fruit of the season? And I was like, I'm so alienated from land, I don't even know what fruits are to what season. I mean, we have so much genetically modified stuff, like, all that stuff's available
all the time.
It was like embarrassed, like, it made me sad, because, like, my dad's side of the family kind of comes from a more farming family in Palestine. I was like, I'm embarrassed. Like, I don't know what fruit is like April is the season, is the month for it. Like, I don't know. But like, that type of alienation we all feel in so many ways, alienation from self, from family, from land, from a world that's so violent that doesn't fit our code of ethics, is all the things we have to help people understand. And if we're not informed about this stuff, how are we going to ever get someone to, feel quote unquote better, whatever that means.
Yes.
Love that.
Yeah. Oh, so we're going to have you back all the time. I will be sending you a calendar and you can just pencil yourself in. That'd be great. But I think too, part of that is because I know in my community, I don't know of anyone like you doing the work that you're doing. And so, yeah, I want people to be able to have access to you even in this little snippet kind of format. And I really appreciate you taking the time to chat with us today, because I think this is important information to get out. But I also recognize that you stay quite busy. So so thank you.
Never too busy for something like this. But I mean, it's sad. You're in New Mexico. Someone I learned from all the time was there, but he just moved to New York. But he was like when he's talking, I just shut up and listen,
Yeah.
So I'm sorry if I spoke too much today.
No.
But I really appreciated this.
So thank you, listeners, for again indulging us in our conversations. And then, as always, in the podcast information, we will make sure that we add some of the resources that we mentioned. And then contact information if you want to hire him, because he needs to get paid for what he's sharing. It's not for free. So I will make sure that the information is there, but please go to social media, because that's what I did before the podcast. Like, where are you? How can I follow you? So we will have that information so that all of you can learn from and continue learning from him. So thank you for being here.
I get paranoid about stuff, so most of my stuff is private. I'll be honest. I'm one of these people that used to have the tape over the camera, and I'm starting to get better about that. But as somebody who was involved in organizing and stuff, like I like to not keep too high of a footprint anywhere. But yeah, so sorry I can't offer much of that to people. Like, I don't really have like a public social media account. My private one used to be just me and my friends eating food, but now it's all Palestine.
You do have a lot of followers. I went into it and I was like, wow.
All right, Liliana, you're really starting to sound like a stalker. So we're going to wrap up the episode before you get served with some papers. And potentially keep in touch with us, because we would love to host you even in an online format to reach more people with what you have to share. So yeah, thank you. And thanks. Yeah, and thanks for hanging in. And until next time, we'll see you.
As always, you will not see us saying goodbye, but just because it's a custom. Until next time.